it's when you've had a surgery and you get a breakdown and a leak, your viscera protrude throughout the out of the incision. Folks with who have a minimal capillary leak with clean wounds, these can be repaired right away. More commonly, folks they've eviscerated in the ICU, and 2 or 3 days later you find them. They've got an ileus, they've got intra-abdominal fluid leaking through the skin, and they've got a contaminated wound. So this is not a wound that you can close primarily right away. What you do in this case, you can place an absorbable polyglycolic mesh to prevent the recurrence of the evisceration, so you protect the abdominal viscera. And you can put a wound vac over top of that, or a staple closure over drains. You can do skin closure either by delayed primary closure, skin grafts, or secondary intention. If you need midline coverage, you can do lateral incisions to allow the skin to come over top. If all you're looking for is skin coverage, and you can either do vacs bilaterally or you wet to dry dressings to allow those to close in. This may look familiar to you guys, as we talked about yesterday in my other lecture. If you got a patient with an open abdomen, you can place a wound vac and check it every 2 to 5 days. If you're unable to close the fascia, the wound vac allows constant pressure, constant medial traction bilaterally to allow you to close the fascia. And in the study we talked about yesterday, 88% closure rate was found at Wake Forest University. I may even have that as the next slide. Yeah, there it is. 43 patients treated at Wake Forest University from 2001 to 2003. 38 out of 43 were closed with a mean of 9.5 days. Go ahead. This is a picture of the wound vac. This is not the exact one that we have these days. This is like the first phase. Basically, you have to cover the viscera of the abdomen, protect it from the vac suction device. Place a sponge, loose suture over top of it. They have an IO-band here. The new kits have exactly everything you need, and they have a sterile drape over top of that. And this is before suction placement, after suction placement. Go back to that. And basically, you repeat this every 2 to 5 days until you can actually close the abdomen, the fascia in the abdomen. You can do a partial closure if you just feel like the patient's becoming unstable. It's interfering with the patient's care. You can do a partial closure and place a mesh at that point in time. That's reasonable to do if it'll help get the patient more mobile, faster. It's certainly reasonable to do. Ways to look for fascial dehiscence: loose abdominal sutures, seroma, which is actually abdominal fluid leaking through the wound. You've done a CT and you've got CT evidence of an evisceration or fascial dehiscence, and you can also do the Q-tip test, which I talked about yesterday, where you place a Q-tip through the abdomen, through the skin wound, down to the fascia, and check for fascial integrity throughout from top to bottom. Early closure is going to increase patient comfort and reduce the chances for bowel injury. Every vac change, every time you go in and do debridement, you have a possibility of bowel injury. Go ahead.